of us, myself included, around the world. The Silver Cross healthcare system in Abuja and eye care system in Abuja have been collaborating partners with us, and we continue to seek ways to improve healthcare system in Nigeria and in West Africa, as well as Africa in general. The Endovascular Clinic, which is a means for us to improve healthcare system by making it affordable in Ikeja, Lagos. The whole idea of the Global Ground Rounds, again, is to ensure that we collaborate with physicians around the world to make sure patients and their families get the best care possible at all times. We have a lot scheduled for presentation today, and would first indicate that if Dr. Ugochi is here, he will join us from Warri, Nigeria. He has an interesting case I'd like to discuss on the platform today. We have student Dr. Vansh, who will be presenting an interesting case of Leriche syndrome, as well as the CERAB procedure, which you'll learn about shortly. And we also have a few other young doctors will be presenting very exciting cases too today, and we'll wrap it up at the conclusion of the program. I also want to also take this opportunity to indicate that the Global Ground Rounds is not geared towards vascular surgery alone. If you as a clinician or physician out there or a healthcare provider feel that you have an interesting medical surgical case that you'd like to present, please feel free to contact us so we can at least showcase your case on our future ground rounds. Our next global ground rounds will be scheduled in the first week of June, the Saturday, first week of June. So without further ado, let's go ahead and get started. Our first case for today. As part of the housekeeping project, please make sure your phone's on mute. At the end of the discussion, we have an opportunity to ask questions as much as you want. All right, the first case to be presented today will be by student Dr. Vansh, and he will be talking about the Leriche syndrome, particularly the CERAB procedure, and a very interesting case that was presented.
Yeah,
Okay. We are just waiting for the first presenter.
Now just share the screen. Share. Presentation.
Paused it for some reason. Where did it pause? Oh, there you go. Okay.
Hi, is everyone able to hear me?
Yeah, we can hear you clearly. And we can see the presentation too. It's good.
So good morning. My name is Vansh Marwaha and I'm a medical student at Alagar University School of Medicine. So the topic which I'm going to present my case report on is advanced endovascular management of Leriche syndrome. That is a case of aortoiliac occlusion treated with CERAB procedure. Next slide, please. Now, if we talk about
Sorry. I know I did. Okay. There.
Okay. So before talking about our case presentation, we have a quick basics of What is Leriche syndrome? Leriche syndrome is a type of aortoiliac occlusive disease characterized by blockages of severe narrowing of distal aorta and iliac arteries. The aortic bifurcation is located at infrarenal aorta, as you can see in the image that is next to the slide, where the aorta divides into left and right common iliac arteries. Then the common iliac arteries further divide into internal iliac that supply the pelvic organs and external iliac that supply the lower extremities. Atherosclerosis can affect this area, causing narrowing or complete occlusion of common iliac and aortic arteries that can lead to symptoms like claudication, limb-threatening ischemia, abdominal discomfort, and dizziness with exertion. The pathophysiology behind this is that atherosclerosis in aortoiliac region can lead to reduced blood flow, causing pain and tissue ischemia. The occlusion affects both iliac arteries, causing the bilateral and increasing the risk for critical limb ischemia if untreated. Now, why did we choose CERAB procedure? Because CERAB procedure is a covered endovascular reconstruction of aortic bifurcation. CERAB is an endovascular procedure used to treat aortoiliac occlusions. It involves the placing covered stents in the bifurcation to restore the blood flow and improve the outcomes. The indications are the aortic iliac occlusion extending into infrarenal aorta. When traditional stenting techniques are insufficient or very high risk, CERAB provides us more anatomical and physiological approach. The advantages for this is it's minimally invasive, it has lower complication rates, and this was first discovered to address the aortoiliac occlusion more anatomically and physiologically than traditional methods. Next slide, please. Now we are having a comparison between kissing stent versus CERAB. If you see the image of kissing stent, it involves the placing two stents in iliac arteries at the aortic bifurcation in parallel manner. While if we talk about CERAB, it uses a covered stent to reconstruct the aortic bifurcation anatomically and physiologically, improving the long-term outcomes by ensuring better coverage and patency. Next slide. Now we have a case presentation of a 68-year-old male presenting with intermittent claudication, lower abdominal discomfort, and dizziness with exertion. Symptoms worsened over the time. He was having severe bilateral leg pain. The past medical history included hypertension, hyperlipidemia, peripheral artery disease. He was having a tobacco abuse disorder. He smokes 2 packs a day for almost more than 30 years. He was having chronic obstructive pulmonary disease, GERD, history of skin cancer, and left lung pulmonary nodule. He has not undergone any major cardiac or abdominal surgeries, but he has a history of bilateral transcarotid artery revascularization for carotid artery stenosis in 2018. The social history included 2 packs per day over 30 years, and he denies any alcohol or substance abuse. Next slide. Now, when we did the diagnostic workup and the imaging findings, it revealed that he is having diminished pulse. His both dorsalis, pedalis, and posterior tibial pulses were weak. He was having claudication symptoms. Laboratory tests revealed he was having mild hyponatremia, leukocytosis. His hemoglobin and platelet count were normal. When we did CTA and runoff, it ruled out that the patient is having complete occlusion of distal aorta and bilateral iliac artery, for which we are having the report in the next slide. So the CTA results, abdomen runoff was performed to assess the extent of vascular occlusion and the condition of aorta and iliac arteries. It showed us the complete occlusion of distal infrarenal abdominal aorta and bilateral common iliac arteries, which confirmed the diagnosis of Leriche syndrome. The 50% stenosis of right common femoral artery and 30 to 40% stenosis of left common femoral artery were also visible in the areas with narrow lumen. This detailed CTA scan was instrumental in diagnosing the condition and guiding the decision for intervention. Next slide. Then for treatment decision, why did we choose CERAB procedure over kissing stent? The indication for intervention was the patient was having severe Leriche syndrome with worsening of symptoms as his claudication was getting worse. He had high-grade occlusion requiring revascularization. So CERAB over open surgery, it is minimal invasive, it has lower risk of complications, it has shorter recovery time, and better long-term patency in aortic iliac occlusion cases. Aortic bifurcation is a very predominant location of atherosclerosis, which can cause claudication and life-threatening ischemia. The CERAB technique has emerged as a preferred option that improved the outcomes by reconstructing the aortic bifurcation in a more anatomical and physiological way. Next slide. So this was the step-by-step that how the interventions were performed. The first thing we did was we had a vascular access via bilateral femoral artery access was obtained through small growing incisions. This step is very crucial to deliver the necessary tools for intervention. Then once we did that, we had exposure of common femoral arteries. The common femoral arteries were carefully exposed to access the iliac and aortic regions for stent placement and balloon angioplasty. Then we did arteriogram and aortogram, which confirmed the complete occlusion of distal aorta, and a detailed vascularization of aortic iliac occlusion was performed. Then we had stent placement. A covered stent was placed in distal aorta, which served as a primary flow channel. We had to place additional stents as well in iliac arteries to restore the bifurcation, improving the blood flow to lower extremities. Next slide. Then we had balloon angioplasty that was done to optimize the stent expansion in aorta and iliac arteries to ensure proper patency and blood flow. Then we had to do endarterectomy. That was an additional procedure. The right common femoral artery was severely narrowed, requiring a plaque removal. So we had a superficial femoral artery and profound artery endarterectomy were also performed to clear the vessel and restore the blood flow. After the femoral arteries were accessed, then we had a crossing of bilateral iliac arteries into the aorta. A catheter was navigated across the bilateral iliac arteries into aorta for the stent placement. Then we did arteriogram to confirm the aortoiliac occlusion and patency of femoral popliteal arteries. And it was used to verify the patency of both the arteries post-intervention. Next slide. Then once we placed it, then we had covered stents deployment and angioplasty, which was to ensure that optimal blood flow and proper vessel wall apposition was done. We had an excellent deposition of infrarenal aorta and iliac arteries post-intervention, and incisions were closed and a drain was placed, and a final angiogram confirmed good circulation throughout the treated vessels. Now I will show you the images how intraoperative arteriogram looked like. So next slide, please. So if you see this intraoperative arteriogram, it clearly shows a complete occlusion of distal infrarenal aorta and bilateral iliac arteries. This image highlights the extent of occlusion before the intervention and provides a visual pathology of what was being treated. This occlusion is a primary cause of patient symptoms of claudication and ischemia in lower extremities. The aorta and iliac arteries' inability to supply the adequate blood flow is visualized, which leads to decision for surgical intervention. Next slide. Now, this image depicts the balloon angioplasty, which was performed on iliac arteries and distal aorta. The balloon was inflated to open up the occluded areas, which improved the blood flow. Angioplasty is a very critical part of procedure to reduce stenosis and ensure that the proper stent has been placed. This image showcases here the balloon catheter positioned within the iliac arteries with the goal of expanding the artery walls and allowing the better stent deployment. Then we have a stent placement within the iliac arteries and distal aorta. These stents are very crucial in treating the occlusion, providing the support to vessel walls and improving the blood flow to the lower extremities. Now, next slide, please. We are having a complete arteriogram that is post-intervention. This showed us the successful restoration of the blood flow after the deployment of stents and balloon angioplasty. This clear image demonstrates the improved patency of the aorta and iliac arteries, confirming that occlusion has been resolved and the blood flow has been restored. The procedure success is visible with no residual blockage, and the patient now has improved circulation to lower extremities. Next slide. So the post-operative course and outcome was we had a drastic change and improvement in distal pulses bilaterally. The patient had a relief from claudication symptoms. There were no complications post the procedure. Post-op management, we had to continue anticoagulation therapy by giving him heparin, pain control with morphine as needed, and gradual reintroduction to the physical activity. The long-term plan was the patient was advised to stop smoking, to regulate his blood pressure and lipid control, and regular vascular follow-ups. Next slide. So why this case is important, like what is the clinical significance of CERAB? It demonstrates us the effectiveness of repair in Leriche syndrome, the endovascular repair. It shows how early intervention can prevent limb loss and improve the quality of life. The aortic bifurcation is a very major site of atherosclerotic occlusion, contributing to symptoms like claudication and limb ischemia. Endovascular interventions like CERAB have shown promising short and mid-term results in terms of patency and interventions. Long-term data is still needed, but CERAB is increasingly seen as a viable option for aortoiliac occlusive disease. Next slide. So the future of CERAB has been included in latest guidelines for treating iliac artery occlusion, extending to infrarenal aorta. However, there are more extensive occlusions where aorta bifemoral bypass remains the preferred approach for the fit patients. Although endovascular therapy is an option, it carries preoperative risk and long-term occlusion rates. So next slide. So these are the references I used. And yeah, so I would like to express my gratitude to Dr. Oye, who has been incredibly mentor and a guide throughout my medical journey. Your exceptional surgical expertise and unwavering support have truly shaped my understanding and approach to patient care. I extend my heartfelt thanks to the patient for their consent to present this case, which has greatly contributed to my learning experience. And I'm also grateful to Raleigh General Hospital for providing us with the opportunity to rotate and gain invaluable clinical exposure. Thank you.
Very well. Next one.
Great presentation.
Thank you.
Any questions for the doctor before I make some comments?
Well, Doctor, this is Dr. Shangri. Thank you for the presentation. Very well done. A couple of things. Typically, Leriche syndrome, the first thing that a layman that is not a vascular surgeon think about is kind of diminished erectile dysfunction. So you didn't mention erectile dysfunction at all. Is this part of the syndrome? Number one. Number two, what is the epidemiology of Leriche syndrome? I think you kind of mentioned that it's very rare, which I agree. But how often do you see this? And this case that you use this procedure, CERAB, is that the first case you are doing in Raleigh General? Or has Dr. Oye been doing this for a while?
Yeah, thank you for your question. So I had to get through the entire chart of the patient, and it was like he did not have erectile dysfunction. So for this patient. And for another thing, for that CERAB procedure, I have been following some articles which I have pasted as link in my references. So it has been seen that in last decade, it has been increasing, but still it is not like that much pronounced yet for like Leriche syndrome for CERAB procedure. Like in the last decade, they have been increasing this technique, but still it has not been that much pronounced yet for the Leriche syndrome. And for the Leriche syndrome, about what cases we are seeing, this was my first case, and I scrubbed in for the surgery with Dr. Oye, so it was good learning experience. But I don't know how many cases Raleigh General Hospital have seen so for this specific disease. Yeah.
Very well. Dr. Shangade, your question is well taken. The concept of complete occlusion of a distal aorta in the iliac arteries certainly does contribute sometimes to decreased flow to the internal iliac artery. If your distal aorta is occluded, and this great chance of blood flow to the internal external iliac will be diminished. Therefore, the blood flow to the lower extremities, the constant claudication, the buttocks claudication, this patient's 3% width becomes significant. And theoretically, it makes sense that some male patients will have erectile dysfunction issues because the internal iliac may not have enough blood flow going through from the distal aorta and the common iliac. So that's correct. Additionally, we've done several of these cases. I routinely do these cases. That's my first line of action when I have distal aortic occlusion. Many years ago, we did aortobifemoral bypasses as a first-line treatment. But as we well know, if we're able to cross lesion, the fundamentals of endovascular surgery depict that if you're able to cross the lesion, you certainly can balloon, put a wire, put a stent. And so that if we can cross the lesion, we're able to do that. With newer techniques that we do have now, the endovascular revolution has been extensive. So we're able to not only go retrograde from the femorals now, and that's the reason why in this case, we made small incisions of growing to really gain control to be able to navigate from the occluded common iliacs into the distal aorta. And if that's not possible, we sometimes go from the brachial, left or right, to kind of cross the lesion. If we're able to cross the lesion, we're able to put stents and prevent the patients from getting an aortobifemoral bypass, which is more debilitating. With aortobifemoral bypasses, they're able to stay in the hospital 3, 4, 5, 6 days, sometimes a week. You have to make that incision in the midline of the abdomen or retroperitoneal. They have a lot of abdominal pain. Their recovery is much slower. They can't eat for about 2 or 3 days. But with this technique, this patient is able to go home, eat the same day, go home the next day because of the groin incision. In this particular case, was able to go home the next day. Yeah, the other patient who might present today was able to go home the same day because we did her percutaneously. So yeah, I do this routinely as my first line treatment.
Well, I noticed that the doctor said there's no long-term follow-up results. Dr. Oye, are you, number one, are you obviously collecting your result to report how good this procedure has been? And number two, I mean, are you still to know those days when we used to do open aortoiliac bypass surgery. That's main surgery. That very morbid. So this is a real good addition to this program. My question is that how often do you have to end up doing aortoiliac bypass if you couldn't do this CERAB?
Yeah, nowadays, for our patient population here in West Virginia and actually globally, we're seeing this problem. From my journeys right here in West Virginia to Africa, patients present with this problem. So it's not that rare anymore. The dichotomy is biggest concern we have in this part of the world, patients smoke a lot. So obviously smoking as a risk factor increases their chance of having the problem. And the other part of the continent, they don't smoke as much, but they still have the problem. And that could be from either dietary reasons where they become adopting the Western lifestyle, or maybe genetics. So in terms of what I experienced is with the Leriche syndrome related programs, it's very common. I do have lots of patients with this problem. So it's not. This is doctor's first case, but I do this routinely.
Good. Thank you very much. I appreciate it.
Thank you.
Thank you, Dr. Oye.
Yes. Hi, Dr. Oye. How are you?
Yeah, fine, thank you. That's a very nice case. From your experience, you mentioned you've done a couple of these. From your experience, have you had to meet with any real form of challenge that, is there an intra-op challenge that in going forward, you always keep that at the back of your mind and prepare to circumvent such difficulty or complication?
Oh, yes. When we see patients with extensive atherosclerotic disease, such as Leriche syndrome, or in this case, distal iliac occlusion, the part of the biggest thing we have to worry about is the workup. The workup should include a CT angiogram pre-op. So we're able to identify the areas of occlusion and the extent of the occlusion. And that way also, the CT angiogram also gives us an idea as to the extent of calcifications the patients may have. So calcium buildup is a huge problem that would make a wire not go through an occlusion that easily. Even though we now have more advanced wires and catheters and techniques that we can use to cross the lesion, it's important that once we cross the lesion in the aorta or in the iliacs, that we're in the true lumen of the vessel. You don't want to go through the adventitia or perforate the vessel. So, and in my experience, I typically, for the distal aorta area, once I've reviewed the CT angiogram, I would decide based on the degree of calcification if I need to approach it percutaneously or with open femoral incision. Again, if the CT angiogram shows you that the patient has a large plaque burden in the common femoral artery area, it makes sense to go ahead and open that area, because you might end up having to do an endarterectomy of that common femoral artery area even after you've treated the proximal disease, so they have good flow downstream. In this particular case that he presented, the patient had an extensive amount of plaque in his right common femoral artery, so endarterectomy was necessary. So that became a hybrid procedure, not only the endovascular portion, but the open portion to remove the plaque from the right from the area. Now, in some of the cases I've also done in the past, if for any reason the wire is not finding true lumen from the groin going up towards the chest, then I could go either from the left brachial artery or the right brachial artery. And you can nowadays, you can also go from the radial artery for radial technique. So those are added tools that we can use to navigate the difficulties of getting through true lumen. If you get to true lumen, then you can immediately balloon. Make sure you do an arteriogram balloon, kind of now make sure you're in the true lumen. Then you can proceed with bigger stents, bigger balloons, and ensure that you don't have the complications. But it's an excellent procedure. If you do it percutaneously, patients will go home same day. If you do it with open intervention, then they may go home the next day. If you do, compared to open surgery where you move the intestines away, if you're doing abdominal incision, they have gas pain, they are uncomfortable, they're having pain, like feel they've been hit by a train for 6 weeks. This is totally almost minimally invasive because they can eat the same day. It's like doing open endovascular surgery where you can eat the same day and go home the next day. So that's the benefit of it. But we still do it by femoral bypasses for those persons where we can't cross the lesion. Then that option's there. We're trained to do both. But the CERAB procedure is definitely the way to go now if we can cross the lesion. Okay. All right. Any further questions or comments before we move on to the next presenter? Okay. Dr. Ugochi, you're in worry. Do you have a presentation ready for us this morning? If you do, we'll let you do the next one. Yes? Do you have your presentation ready? You're off.
Yes, I have it. I have it. I'm ready.
Okay, let's do, because you missed the presentation last time, let's go ahead and have you load it up, and we'll let you present your case for Maury, so that way we will get ready for the next presentation here from Beckley.
Okay.
Sad, can you connect and do it for him?
Yeah, sure. Which presentation? You sent me two.
Dr. Ugochi's presentation.
That is the case, polymyositis.
Okay.
For him, he presents. Let's see.
All right. Can you see it?
Yes.
No, not yet. Yes, I can see it. I can see it. Thank you.
No problem.
Thank you. So, good afternoon, all. Let me first of all thank Dr. Oye for the good work you're doing and for your mentorship, and also for getting me into this global grand round to do this presentation. I'm really honored. Let me not take much of our time. I'll be presenting a case of polymyositis. I've chosen this case because of the lessons for us, primary care physician. I practice family medicine. Next slide, please. Okay. Can you project this? Sad, can you project this?
Sure. Just a second.
Yeah.
We can see it.
Okay. Okay, I'm presenting a 56, fine. Okay, next slide. Yeah, a 56-year-old widow with a month's history of insidious progressive muscle weakness and pain, for which she was treated for malaria twice before a diagnosis of autoimmune polymyositis was made. She described muscle pain as worse when standing from sitting position and with IV quinine administration, because that was used in treating her the second visit. Other associated symptoms included joint pains, difficulty putting on her headgear, unintentional weight loss. She denied any history of fever, rash, morning stiffness, coughing, dyspnea, painful or difficult swallowing. Significant examination findings include difficulty rising from sitting position, reduced gross muscle power of the adductors and abductors, and knee flexion, power being strong 3/5. Intact muscle bulk was seen globally. The limited shoulder abduction was also observed. Her pulse rate was 104 beats per minute. Respiratory rate was 20 cycles per minute. Next slide, please. Next slide, please. She's a known hypertensive with peptic ulcer disease, diagnosed endoscopically, and was doing well with that. A drug history, she was on amlodipine, normoretic, and rabeprazole. Remarkable laboratory results that points to the diagnosis of polymyositis include markedly elevated ESR 125, C-reactive protein is, that wasn't significantly raised. Highly specific C-reactive protein wasn't highly significantly elevated, but the creatinine kinase, which is one of the muscle enzymes, was significantly elevated. 11,275 was obtained as the threshold, the normal upper limit of the normal range is 500. Anti-Jo1 antibodies was elevated, was more than 200. That shouldn't be more than 15. She had a negative anti-nuclear antibody, a negative MI2 antibodies, which is another muscle enzyme, borderline PCV of 33%. The white blood cell count was essentially normal. Same for the liver function test, kidney function, thyroid function. She had a pre-diabetic range and value for HbA1c of 6.3 and a fasting blood sugar of 119, which is also pre-diabetic. Next slide. She was started on high-dose prednisolone, 60 milligram BD, and was later reduced to 45 milligram BD because of worrisome diarrhea. This led to significant drop in ESR that was repeated and an improvement in the range of motion of the deltoid muscles as she was able to control and move her shoulders a bit more freely. She was later referred to see a rheumatologist who added an immunosuppressant. In fact, he added methotrexate after an initial course of hydroxychloroquine that didn't make much difference. The prednisolone was later reduced, and she was started on prophylactic, what we call prophylactic gavus, that is vidaglipin and metformin combination for the pre-diabetes. She also was placed on calcium and vitamin D3, and then received graduated physiotherapy and walking exercises. Next slide. What the literature has for polymyositis, just a brief. Polymyositis is an idiopathic inflammatory myopathy that is very rare. It's characterized by symmetrical proximal muscle weakness, elevated skeletal muscle enzymes, characteristic electromyographic and muscle biopsy findings. The epidemiology, in the past, it was really rare, rarely reported in Africa, but some cases have been seen. The first case reported was in South Africa. And ever since then, many other cases have been seen, not only in South Africa, but in other parts of Africa, including Senegal and Nigeria. A systematic review reported a global incidence of 8.8 in 1 million person years. In the United States, it is rare, it's described as rare also, with an incidence of 0.5 to 8.4 cases per million population. It's commoner in the Black Americans with a 2-to-1 female-male ratio. A case series in Nigeria reported a 13-to-1 female-male ratio. It usually affects adults greater than 20 years. It's very rare in children, particularly 45 to 60 years of age. Studies in Africa have reported earlier years at onset, with a median of 35 years. Next slide, please. The etiology is known to be an immune-mediated syndrome secondary to a defective cellular immunity, the T cell in particular, that is most commonly associated with other systemic autoimmune diseases. Common risk factors include HLA haplotypes A1, B8, and D3. Environmental triggers include many infectious agents, especially viral infections like Coxsackie virus, B1, HIV virus, human T cell, leukotropic virus 1, hepatitis B virus, influenza, and in our environment, Salmonella typhi that causes enteric fever is also known as a trigger. Some other triggers include smoking and some pollutants like silica. Next slide, please. Next slide, please. The pathophysiology, like I mentioned, is mainly a T-cell mediated cytotoxic process that is directed against a yet to be identified muscle antigen. The clinical features include mainly gradually increasing muscle weakness spanning over 3 to 6 months. Like our case, it was within a month we picked that. Unlike dermatomyositis, which is another idiopathic disease, it is preceded with distinct rashes, facilitating early diagnosis. Diagnosis of polymyositis is usually delayed, hence the need for a high index of suspicion. It may also present with constitutional symptoms like fever, anorexia, myalgia, which are commonly seen in malaria and other febrile, infective and non-infective diseases. Typical findings include symmetrical muscle, proximal muscle weakness, more in the pelvic than the upper body, bulky muscles. So, myalgias in 30%, dysphasias in 30%, arthralgias, difficulty in kneeling, climbing or ascending stairs, stepping on stools, raising arms, lifting objects, combing the hair, and rising from sitting position. They also have difficulty holding the neck up in some cases. Fine motor movements like we engage in writing, sewing, knitting can also become problematic, and these are usually late manifestations. Next slide, please. Okay, this is the most widely accepted classification for idiopathic inflammatory myositis by Bowen and Peter. We have 6 grades in categorization there, classifications: primary idiopathic polymyositis, primary idiopathic dermatomyositis, polymyositis or dermatomyositis associated with malignancy, childhood polymyositis or dermatomyositis, polymyositis or dermatomyositis associated with another connective tissue disorder, and then the miscellaneous group. Next slide, please. Other clinical features may include morning stiffness, fatigue, anorexia, fever. Fever usually seen in patients that have anti-Jo1 antibody. Weight loss, interstitial lung disease, same is also associated with presence of anti-Jo1 antibody. Constipation or dinophagia. And complications include aspiration pneumonia, interstitial lung disease, hypoventilation, increased incidence of malignancies, especially breast and lung malignancies, ambulatory dysfunction, heart block, malabsorption, myocardial infarction, I mentioned that, steroid myopathy, which is an iatrogenic manifestation, congestive cardiac failure, increased risk of thrombosis and pulmonary embolism. Next slide, please. Others include hypokalemia. These are differential diagnoses. Differential diagnoses include hypokalemia, hypothyroidism, myasthenia gravis, myositis ossificans, giant cell myositis, and muscular dystrophy. Drug-induced myopathy is also known as a differential. We get that from alcohol. Alcohol abusers, they can also manifest with that. Anti-malarials like chloroquine can also cause myopathy, colchicine, antifungals like ketoconazole, then statins, very notorious for that because they can cause muscle inflammation and rhabdomyolysis. They can also cause a form of autoimmune inflammatory, idiopathic inflammatory myositis. D-penicillamine, hydroxychloroquine, has to be corrected. Hydralazine, phenytoin, and ACE inhibitors. All these are possible differential diagnosis for myositis, polymyositis. Diagnosis. The diagnosis primarily definitely diagnosis by muscle biopsy taken from the quadriceps, but some other relevant investigations that point to the diagnosis includes full blood count in 50%, thrombocytosis, high pretreatment neutrophil lymphocyte ratio of 5.5, which is usually associated with cancer. Raised ESR, raised CRP, we had that. The muscle enzymes, we had that in our patients. Creatinine kinase was markedly elevated. And then we also have LDH and ALT. They may be elevated. Myoglobinuria may be seen. Autoimmune antibodies, especially muscle-specific antibodies like anti-Jo1 antibody and MI2 antibody. Imaging studies for associated malignancy that are also relevant, like chest X-ray, pelvic ultrasound, mammography, and CT scan. For our patient, we did a chest X-ray and mammogram, and they were all negative. Electromyography, ECG echo, they are also associated. Ancillary investigations that can be done. Biopsy is the definitive for, definitive diagnosis can be made via biopsy, and it's usually taken from the deltoid or the quadriceps muscle. Next slide, please. Next slide. Next slide, please. The next slide. Steroid is first line treatment, and we did that for our patient, and response can be very dramatic in 80% of cases. Immunosuppressants and cytotoxics like methotrexate, azathioprine, cyclosporine can be used. Our patient got methotrexate. Limited data supports the use of tumor necrotic factor inhibitors, calcineurin inhibitors, and CD20 monoclonal antibody. Also, mycophenolate morphetyl can be used. High protein diet is advised for such patients. Physical activity and physiotherapy, usually graduated as patients tolerate. Next slide, please. The follow-up initially should be frequent, and then subsequently, as patients get better, can be extended to monthly and even quarterly checks. Regular check of creatinine kinase is the mainstay in follow-up of patients. As it drops, values drop as the disease, the inflammatory condition resolves. Regular muscle strength evaluation, screening for cancer, using breast mammogram, chest X-ray, and CT scan may apply. Weight check at every visit is important. We also watch out for complications of long-term steroid use. Our patients suffer this, but as we speak, the patient is now being managed for diabetes, and we are gradually tailing off prednisolone. And hopefully, we should be able to reverse this diabetes. Hopefully, so we deal with osteoporosis by doing baseline bone density scan. Next slide, please. Now, the take-home lessons. This is because as a primary care physician, this is one case that struck me. Polymyositis is increasing in incidence in Africa. It's not, we can't say it's rare anymore, really. Its main clinical presentation of symmetrical muscle weakness is gradual in onset, and so high diagnosis, mimicking common tropical diseases like malaria, which is saying that we are deceived at least twice. Hence, a high index of suspicion should be entertained. Weakness in adults, especially females, not responding to malaria treatment after a month should prompt the possibility of polymyositis. Difficulty rising from sitting position with or without pain should also trigger consideration for polymyositis. High-dose steroid is beneficial, but could be harmful in the majority of patients, as was harmful to our patients. Screening for associated malignancy is vital. Thank you. That is the end of my presentation. Thank you. I can take questions or contributions.
Thank you,
Dr.
Dr.
Ugochi,
Yes, sir.
Thank you very much for your beautiful presentation. So, number one, let me ask, how is your patient doing? Is she recovering from her symptoms? I know she has steroid-induced diabetes, but how is she
Yeah.
doing with symptoms?
Oh, she has no more symptoms of weakness in any of her
Good,
muscles. No more symptoms. She's
good.
back to her work. She's a school administrative officer. She's up and doing everywhere. She's fine. The
Okay, good job.
creatinine kinase, the creatinine kinase as at the last check was 190 thereabout. So she's almost it's almost resolved, I would say.
Good.
But we still
Well,
keep her on methotrexate for a while. Gradually, we've considered working in conjunction with the rheumatologist to begin to withdraw the methotrexate.
Well, second question. I mean, you in a resource scare area that you practice. I was impressed that you did all these tests and you were able to get all this expensive medication for her. How did you get that? What was the financial and the social impact of that to the patient, or does she? I
Okay,
mean,
okay,
give us an
okay.
idea, because this is a global run, and we're trying to learn from you from a resource scared area. How are you able to get all these tests done? Who finance it? Who pay for it? And all this expensive medicine like methotrexate, how did you get them?
Thank you for that, sir. To start with, this patient, I oversee the health of persons in a community. It's a faith-based, a church organization, the missionary hospital I work for. So I oversee the health, by God's grace, of the ministers and their wives. So this happened to be a minister's wife, and for this category of patients I see here, there is no limit. And we have some very good lab. We have SIN lab, we have a cleaner lab, and those labs do almost everything you can require, from antibodies, from drug levels checks. They do everything. So we have
I'm very impressed. That's good.
that support. We have that support here. Those
Good.
two
Thank
labs.
you.
Yeah.
Yeah, thank you. That's very impressive. It's good
Yes.
to be a minister's wife in Nigeria. Thank you.
I love that.
Dr. Gaji, nice talk. Can you hear me?
Yes, I can hear you.
Yeah, one of the concerns one would have with a case of elevated creatine kinase due to muscle breakdown would be
Yeah.
possibility of renal failure.
Right, yeah, exactly.
Your patient developed renal failure during the course of this treatment.
Yes, we only use urinalysis. We didn't find anything. We just did urinalysis, and
But the
it was clean. Our
BN
kidney function was fine.
Right, because that would be a concern when you have rhabdomyolysis, extensive
Yes.
rhabdomyolysis.
Yes,
Obviously,
it was monitored.
to renal failure. Very good. Again,
Absolutely, yeah.
Again, the concern also which is important, there should be more than one diagnosis entertained in the differential diagnosis for patients' problems. And you did do an extensive, good review of the potential diagnosis.
Yes. Yeah.
But we know from my experience when I go to Nigeria, most of the diagnosis is malaria. It's like there's no second.
It's not always malaria. That's what I tell my medical officers. It's not always malaria.
Malaria and typhoid are they may have something. Very good. Thank you very much for the interesting talk.
Yeah, you're welcome.
All right.
Yeah, welcome. Thank you.
Question for you from Dr. Vansh.
Okay.
Yeah. So I wanted to ask you, like, if we are giving high dose steroid therapy to these patients, so whether the therapy is working well or not, so what markers apart from creatinine kinase, like, I know, like, I have just a theoretical knowledge that we have studied that when there is increased creatinine kinase, that is the marker we test for polymyositis and dermatomyositis. So let's say steroids are working. So will you check these markers that whether they're working well or not?
Oh, yes, we did. She's done over 20 creatinine kinase checks in our follow-up. Oh, we did.
Any other we use? I'm not aware about it, but apart from creatine kinase, is there any other marker we can use whether the medicine is working or not to check that?
Okay, ESR is.
Yes, Howard. Thank you. Yeah. All right, very well. Thank you so much.
ESR is sustainability.
Thank you,
ESR
Dr.
will just
Ugochi. We'll
continue to
get
look
our
down
next
with it, yeah.
presenter here.
Yes.
You go put up. Yeah.
Okay, thank you.
Sad, our next presenter.
What? I think I'll take it.
Okay. Our next presenter is student Dr. Alagar. She had done a rotation with us at Raleigh General Hospital, and she has an interesting case to present. We look forward to our presentation.
Thank you. Hi, my name is Indra. I'm a third year. What? You're not sure. That's it.
Sad. Can you
No, I'm-
share the image
Okay,
first?
yeah, I got it.
We can see it now. Yeah.
Okay, yeah. Thank you. Hi, my name is Indra Alagar. I'm a third year medical student at Avalon School of Medicine, and I rotated with Dr. Oye in December of 2024 at Raleigh General during my vascular surgery rotation. And I thank him for his guidance and his mentorship. And I will present 3 cases. My first case is a 56-year-old female with leg pain. So this patient was diagnosed with peripheral arterial disease. So to give an overview, PAD affects approximately 200 million individuals worldwide, causing an estimated 60% of excess of all-cause mortality overall. And it accounts for up to 4% of amputations. And it is defined as the blockage or narrowing of arteries due to the accumulation of fatty plaques. And so PAD can indicate major obstructive atherosclerotic disease, which can affect the cerebral and coronary vasculature in the brain and heart, which are vital organs. So this over time can increase the risk of stroke and cardiovascular events. So major risk factors for PAD include hypertension, high cholesterol, diabetes, and smoking. So these are all like due to like a lot of lifestyle factors combined with like pathophysiology. And PAD can range in various forms from being asymptomatic with no symptoms at all to the most severe form, which is critical limb ischemia. So I adapted these from the 2024 clinical practice guidelines on management of asymptomatic lower limb PAD and intermittent claudication, published by the European Society for Vascular Surgery. So on the left, this shows the different anatomical locations for atherosclerotic lesions in different parts of the vasculature, so the aortoiliac and infrainguinal artery. So this is kind of like how the vasculature travels in the lower limbs. And as I mentioned, PAD can range in different severity, and it presents typically in patients with difficulty, like pain with walking, and as well as different like physical manifestations like ulcers on their skin and pain at rest. So on the right, these are the different classifications of PAD. So stage 1 is asymptomatic. So objectively, they have a normal test on the treadmill when they walk. And then stage 2 is when claudication presents. And so objectively, their ankle pressure and their toe pressure are slightly abnormal with exercise. And then stage 3 presents as rest pain. So patients can have pain like in their feet at rest. And as you see, there's different like criteria for the resting ankle and toe pressures. And stage 4 is severe and it can present as ulceration, gangrene of the limb. So like this is present on physical exam with like breakdown of the skin and ensuing manifestations. So like tissue damage ensues. And the resting ankle and toe pressure are higher now. So it has a wide differential diagnosis, which could include many things, like many different neurovasculature differentials. So Baker's cyst is like on the differential, can happen in the like popliteal arteries behind the knees. Lymphangitis, cellulitis, DVT, cystic adventitial degeneration. These are all kind of like breakdown of the vasculature and like of the skin as well. Thromboangiitis obliterans, this can happen with smokers. Popliteal arterial entrapment syndrome, spinal cord stenosis, chronic exertional compartment syndrome, no root compression, photo ankle arthritis, and hip arthritis. So as you can imagine, a lot of these differentials are like neurovascular related, and they can like drastically affect quality of life because they like concern mobility in patients. So this is from the 2017 European Society for Vascular Surgery guidelines for the diagnosis and treatment of PAD. So these are like their recommendations regarding the management. So revascularization of aortoiliac and femoral popliteal occlusive lesions. So this kind of displays like the different like algorithms in deciding for the clinical management. So in our case, a common femoral endarterectomy was performed. So the CFA is the most commonly accessed site for endovascular procedures, and typically the stenotic lesion occurs at the site of bifurcation, like where the CFA branches into other arteries. So it has unique characteristics. So the CFA has like pretty great bulk and calcification. And so balloon angioplasty is limited because there's different risks of the placement of the stent, which includes the fracture of the stent, intimal hyperplasia, and the sacrifice of the deep femoral artery, which can lead to embolization, the high risk of that. So CFAE is considered a fairly low risk procedure, it's short duration, and it's effective in relieving breast pain and limb claudication symptoms, and is shown to result in favorable long-term patency and limb salvage for patients. And there's a hybrid technique that has been studied where CFAE is combined with endovascular therapy, and it's less invasive, but shown to have similar efficacy, especially in patients with multi-level occlusive disease. It is more like widespread. And I found this retrospective study published in 2018 by Kim and colleagues, where they concluded that CFAE alone is a safe, durable, and effective procedure and the standard treatment option for excellent patency and clinical improvement for steno-occlusive lesions confined to the CFA. And there's a variety of post-operative complications. So this study compared, studied almost 2,000 cases of isolated CFE between 2005 and 2010, assessing outcomes from 30-day follow-up. And the authors found 6 different independent predictors for death in these patients, which were age, non-independent functional status, preoperative sepsis, preoperative dialysis, emergency surgery, and ASA physical status class greater than 3. And the authors also concluded that there were different kinds of wound complications, including infection, hematoma, and seroma. And fortunately, major organ dysfunction, like renal or like lung or heart major complications, was rare. However, there was a high risk of reintervention following the initial procedure. So the causes of these included postoperative bleeding, thrombosis, and infective pseudoaneurysm. So the authors concluded that CFAE, while it is widely considered like safe and effective, it is not as benign as was previously thought because there were non-insignificant risk of postoperative complications. Therefore, patients should be cautiously selected, and close postoperative follow-up and comprehensive wound care should be emphasized in their clinical course. So our case at Raleigh General was a 56-year-old female with PAD and leg pain. And they had right femoral popliteal artery stenosis and common femoral artery occlusion. And these are some images of the angiography stents and aortoiliac arteriogram. And these are images from the angioplasty. Right iliac angioplasty was performed. And there was an estimated blood loss of 1,200 milliliters of blood. And below, you can see the plaque specimen from the right femoral artery. My references. My next case is a 72-year-old male with severe PAD. So this patient had occlusion in the right external iliac, common femoral artery, superficial femoral artery, and as well as their left superficial artery and popliteal artery. So in this case, a right femoral iliac artery bypass and a bilateral femoral endarterectomy were performed. So those are the specimens of plaque from the right and left femoral arteries, and the EBL was 400 milliliters. My last case is a 65-year-old male with bilateral carotid stenosis. So carotid stenosis affects the cerebral vasculature. As you can see, it's depicted on the left anatomically. And the CCA, which is the common carotid artery, branches into the internal and external carotid arteries, and that's an image of stenosis on radiology. So CAS overview, it's a major cause of stroke, which is the third leading cause of mortality and major cause of disability worldwide. So ischemic strokes is one classification, and it includes stenosis, clot, and emboli. And this accounts for the vast majority of strokes, around like 80 to 85%. And there's different kinds of carotid artery stenosis. So extracranial, which is outside the direct brain vasculature, accounts for around 30% of all strokes. Intracranial CAS is 5 to 10% of all strokes. And it has been found that there's a direct relationship between risk of stroke and degree of state CAS. So, for example, there's a less than 1% increased annual stroke risk, with CAS less than 80%. This is compared to almost 5% increase with a stroke per year with CAS greater than 90%. And there's different risk factors, including increasing age, elevated cardiovascular risk, dyslipidemia, hypertension, diabetes, obesity, PAD, male gender, and smoking. So atherosclerosis happens when the interior wall of an artery thickens, and there is this like multifactorial interplay between the development of fatty and fibrous cap lesions, and the hemodynamic forces like inside the vasculature are oftentimes disrupted, and reactive oxygen species build up, causing inflammation over time. So it's kind of like a multifaceted pathophysiology. And over time, thrombi form, leading to occlusion of arteries. So for carotid artery stenosis in particular, it's important to do like a very thorough exam. So the patient will typically present with focal neurologic deficits, including weakness, visual disturbances, and cranial nerve deficits, slurred speech, and dizziness. So it's very important for the physician to perform a thorough neurologic, visual fields, cardiovascular, skin, and extremity exam, which will evaluate for like coolness, loss of pulses, discoloration, and loss of hair. And again, there's a pretty wide differential, which includes various vascular pathologies. So CES, as I mentioned, is a progressive narrowing of the carotid arteries, and the development of plaques can occur at the branch ostia and bifurcation of the CCA into the ACA and ICA. And there's different clinical syndromes that result, including asymptomatic or transient ischemic attacks or ischemic stroke. And symptomatic manifestations will include like ipsilateral, cerebral, or retinal ischemia, which is a block to the like brain and eyes respectively. So for the workup, a carotid duplex ultrasound is important. It's non-invasive and inexpensive, and asymptomatic patients with risk factors will be evaluated and with surveillance at 6-month intervals. And so CT and MRI imaging and arteriography can further visualize the plaque characteristics, and it can help in surgical planning. So overall, like lifestyle modifications are important for patients, as well as pharmacological therapies for lowering their comorbid conditions. And oftentimes it's important to have like a thorough risk benefit discussion for deciding for medical versus surgical options for patients. So there's different approaches for surgical treatment of carotid stenosis. So carotid endarterectomy is when the carotid arteries are opened and plaque is removed. And studies have shown that there is a benefit in patients with moderate to severe stenosis. And it's recommended for patients with asymptomatic CAS of 50 to 60%. Next is carotid artery stenting, which is less invasive than CAA and preferred in patients with comorbidities in the head and neck region, which would prevent CAA many times. However, there's a significantly high risk of distal emboli. And studies have shown improved neurocognitive functioning, which includes like evidence for like better like speech, vision, movement, etc. In patients who underwent CAS. And evidence shows that CAS is more beneficial for patients younger than 70 years, whereas CAA is more beneficial in older patients. And then next is transcarotid artery revascularization, TCAR, which is less invasive compared to the other two options because there's a smaller surgical incision. And there's a lower risk of stroke or death compared to CAS, and lower likelihoods of in-hospital and postoperative complications. It's important to consider different things for the CEA intervention. So these were different trials in 1991 that were landmark studies. So CEA for symptomatic CS underwent within 6 weeks, that should be weeks, of predisposing event, resulted in a significant reduction of risk for recurrent stroke. So this was an important finding, and the authors found that the greatest benefit of CEA was within 2 weeks of the ischemic event. And so now guidelines recommend CEA to be undergone within 14 days of the event. In 2012, there was a study in the Swedish Vascular Registry, which found that there was an elevated risk of perioperative complications when CEA was performed within 48 hours of the event, as compared to performed with later on, like 3 to 7 days after the event. So they found that there was like 11.5% risk of complications within 2 days versus 3.6, potentially lower within 1 week after the event. So again, it's important to like have a thorough discussion with patients regarding their preferences, an assessment of their neurologic compromise and their functionality for determining the optimal timing for the CEA. So back to the case, again, it was a 65-year-old male with bilateral CAS. So the right carotid artery showed 66% occlusion, and the left carotid artery showed 70% occlusion. And so a right TCAR was, right total carotid endarterectomy was performed with an EVL of 100 milliliters.
The TA or TCAR?
Total carotid endarterectomy. CEA.
TCAR?
Should be CEA.
CEA?
Yeah.
That's unusual. With that high plaque, expect TCAR. All right.
Thank you so much, Dr. Oye, and for my rotation and the opportunity to present today.
Any questions from the audience, please? Thank you, very
Well,
much.
that was good. That was very good presentation, Doc. Question is, you in your presentation as to the etiology, most of what come through is smoking. Now that the rest of the world is increasingly taking a Western type of lifestyle, if you are the minister of a real small country in Africa, what will you do to prevent this kind of diseases getting big in that kind of country? What will be your recommendation as to prevention? I mean, we're trying to make sure that all this Western disease doesn't get into our country in Africa, but it's getting difficult because everybody's eating McDonald's and hamburger and getting lazy. Everything is automized and smoking, drinking. So with particular to peripheral vascular disease, basically what I'm asking you, what would be a major prevention intervention for you to implement?
I think like patient education should be thoroughly emphasized for those populations, just educating about like the risk of lifestyle factors, like over time, like if they like eat a very like non-nutritious diet or smoke or drink like multiple times a week, just emphasize the importance of like cutting down on those kinds of lifestyle things, because over time it can cause these very dramatic consequences with their vascular system in the body, even if like they don't think it's that severe, like on the day-to-day, but over time, just like emphasizing that to populations, and just like kind of prioritizing like different public health initiatives like that, like collaborating with different practitioners in the healthcare space.
Good, thank you very much.
Can I add a voice?
Sure.
Okay, yes, we are not ready for these diseases. We are not ready. But unfortunately, the numbers are increasing in our environment. Like you asked, thank you for the beautiful presentation. Quite very enlightening. We see lots of stroke here. And unfortunately, we get lots of reoccurrences. Very sadly, these interventions are not here. And we should do everything possible in Africa, this part of our world, to prevent such incidents, adverse incidents. Yes, if you're going to be made a minister, that's the question. What will be your advice in terms of like a bullet, a good bullet that will reverse, stop the trend? That bullet will be, to control what these fast food industries that are all over the place, what they use in preparing their meals. You have to regulate, and they should meet proper standards of, healthy nutrition. The types of oil, the quantity of salt. That is one way. Yes, we can adopt whatever they're eating, but the quantity of the type of oil, the type of salt, or the quantity of salt, they should be regulated. There's no regulation anywhere in the world. Even in the West, there's no regulation. That should also be, that is one way. And then, of course, incentivize fruit and vegetable planting. If those two are done in Africa, they will go a long way. So they will make fruits and vegetables very readily. They're very scarce. I have patients, I invest a lot, but how many patients have the value, place that value on fruits and vegetables? They don't see it, and when they see it, they're so expensive. So that is something any minister should be interested in, making it available. So then the meals should be regulated. What people eat outside their homes should be regulated. Thank you.
Thank you, Dr. Ugochi. Yeah, interesting talk from the first talk to the second talk to the third talk now. What I see essentially, if I have to start with a stroke, stroke is a major problem here in the United States as well as other parts of the world, as she's stated, about a third leading cause of death before the COVID came around. The main issue here is identifying those patients at risk and doing something about it. Here in the United States, even in Beckley, we're able to identify a patient with stroke and take immediate action even before they get to the hospital. A call goes into the hospital that the patient is coming. We take necessary precautions, immediate CAT scans taken when they come in. We identify if it's a hemorrhagic stroke or ischemic stroke. If it's ischemic stroke, we give them TPA. If it's hemorrhagic, obviously you don't want to do that. And then, we proceed to appropriate treatment immediately based on the findings. Again, it's a different story because the stroke events in Nigeria as well as other parts of Africa is a little more different, but it's maybe more stress related because these patients are quite hypertensive and they get more hemorrhagic type strokes, but they still do have some ischemic strokes also. Then if you move away from that to the leg problem, first case, the Leriche syndrome case that was mentioned, one of the things that's important for non-physicians in the audience, it's important that when the physicians examine the patients, we sometimes can make the diagnosis even without ordering expensive tests. For Leriche syndrome, for example, we're able to check the femoral pulses. If the patients don't have femoral pulse in the groin area, that tells us a blockage high up from the groin up. So that will increase the risk or the possibility that the patient may have Leriche syndrome. So that's a quick way for when I train students to tell them to check pulses. So that's one way to do that. Then for the second case, when patients walk, they have the pain. But for Leriche syndrome, they have the buttocks pain, the buttocks pain, the back of the thigh. Then for the case she presented, patients who present with rest pain with pain with ambulation, intermittent claudication. Then they have pain at rest. Then they have pain that can become worse where they have tissue loss or gangrene. So that's a spectrum that we typically see. The blood pressure readings for that, if we in a community that does not have CAT scan, for example, all we need to do is the ankle brachial index, which is a measure of the blood pressure of the upper extremity, ankle to the upper extremities. We're able to have a ratio of 1. Ratio of 1 or greater tells us that they have normal blood flow. If the number is extremely low, less than 50% or 0.5, they have severe arterial insufficiency. And that will now prompt us as to what we need to do. If the patient's problem is a recent problem, just started immediately, then you're thinking maybe it's a clot issue. If something's been lingering for many months, it's a chronic problem. The worst case scenario is where somebody has an ischemic leg where they come in, the leg is cold, it's painful, it's pale, they have no blood flow going through it. They will lose the limbs if you don't take urgent steps to prevent that. So as part of training or experience persons on this platform, if you have a family member, friend, or patient that has complaint of leg pain, it's important that you are able to ascertain almost immediately if it's a new onset problem, if it's a problem that's been ongoing for many months, and if they have the no pulse, the cold, it's painful, all those things would determine whether or not it's an acute problem or if it's a chronic problem. So that way they can seek help early. If an arterial problem is missed, they can get an amputation as the end result. In most African countries, the rates of amputation can be as high as 80% because they sometimes don't have the opportunity to have the fancy test that we have on this part of the world to save limbs. They just go for the only thing they can have, which is the amputation, because these patients present late in their course. They have the pain for financial reasons, can't afford care, so they go to their pastors or prayers, thinking that the problem will go away, and sometimes doesn't go away, and they end up losing a limb. So those are some concerns that we do have. Again, I'd like to move this on by thanking the docs for a nice presentation. We'll move our next presenter, student Dr. Bailey Downs. She will talk to us again on an interesting topic, and we'll conclude this session here. Thank you.
Do I need this at all?
Yeah, keep it up because I'm gonna use that for, I'm gonna keep mine up so I can talk into that, right?
Okay. Can you, yeah.
I shared my screen, so hopefully.
Really down.
Are you presenting?
Yeah. Just. Stop. And then. Yeah, I'm sure. The screen. Can everyone see that?
Yeah, we can see it.
Yeah, we can see.
All right, so I'm Bailey Downs. I'm a third year medical student working with Dr. Oye right now on my vascular surgery rotation. And we recently had this pretty interesting case that I'm going to present to you all. And, right, so this case presentation is on some patient presenting with bilateral subclavian vein stenosis and superior vena cava syndrome. And I'll just refer to it as SVC syndrome. So some background. SVC syndrome occurs when there's an obstruction of the superior vena cava. It can be caused by either a thrombus or any type of external compression, which then impairs the venous flow, basically to the heart, resulting in the upper venous congestion. It can present with facial and upper extremity edema, some dilated superficial veins, and dyspnea from the external pressure. And then the subclavian veins are critical for draining the upper extremities. In this case presentation, a unique clinical scenario where bilateral subclavian vein stenosis is seen along with the development of SVC syndrome. This patient has a very interesting medical history that adds to her clinical course, which will be discussed along with the diagnostic approach and management of this vascular case. So some of the patient background was a 40-year-old white female, was sent to the ER by her oncologist due to some neck pain and swelling, some redness and warmth and shortness of breath for the past 2 days, which they were concerned for DVT or possible clot in her Mediport. She had not used her Mediport or received chemotherapy for the past 2 weeks, and no other complications were noted at this time. So some of her past medical history, she was actually diagnosed with stage 3 colon cancer at the age of 28 and has since become stage 4 with metastasis to her ovaries, uterus, lungs, left adrenal gland, and bone. She's been on all types of chemotherapy and has never in the past 12 years been in remission. She also has multiple sclerosis, anxiety, depression, bipolar, hyperlipidemia, fibromyalgia, and migraines, and then a history of DVT and PE, and she was on Eliquis. So her past surgical history includes colon resection, right lung lobectomy, a hysterectomy with a bilateral salpingo-oophorectomy, LEAP procedure, and then the Mediport placement in her left chest, mostly for the chemotherapy. So on clinical examination, she did look ill-appearing and had some anxiety. Her vitals were overall not too bad, other than some tachy, and her O2 sat was a little low. She did have some neck swelling and lymphadenopathy, mostly on the right side, with some tenderness noted, but no carotid bruits were heard. Other than that, everything else was looking okay. And then some diagnostics. When they did an upper extremity venous Doppler, it was negative. Those are some of her labs there, nothing too crazy. Her cardiac markers were negative. And then her CT angiogram of the chest was negative for PE, but they did see a left atrial thrombus that was persistent with unchanged endobronchial mass, with a complete collapse of the right lower lobe with mediastinal lymphadenopathy, and then a progressive narrowing of her SVC with some collateral flow in her right upper extremity. And this is when vascular surgery was consulted for the venogram. So how we were gonna manage and proceed here, so Dr. Oye is gonna do bilateral subclavian vein venogram with possible angioplasty, stenting, and then taking a look at her Mediport too to make sure there was no clogging in that, and possibly remove it and replace it. So the diagnoses going in were bilateral subclavian vein stenosis with near occlusion, left subclavian Mediport, bilateral facial neck swelling secondary to SVC syndrome, and superior vein stenosis, and then that history of colorectal cancer with the lung metastasis with the SVC syndrome. So these are the procedures that were performed when we went in. I'll show you some pictures going along with these. Also, I just wanted to show you the performed procedures in a row here. So we did some angioplasty at the left subclavian vein with increasing size of balloons, stenting of the left subclavian vein with a stent or a fluency plus stent, And then balloon angioplasty of the right subclavian vein with increasing sizes of balloons, with then deployment of a stent in that as well, with the fluency plus stent in the right subclavian. And then we did end up removing and replacing her metaport in the left subclavian vein. So I'm going to show some pictures. This is just the venogram of the subclavian, both subclavian veins, and you can see the stenosis here. So the angiocath was placed in the right upper extremity when we did this, and the right subclavian vein and internal jugular veins entering the SVC, it showed near occlusion, and then her left metaport catheter showing complete vascular vein occlusion. And here's when we went in with the balloons. A glide catheter was exchanged for an advantage guide wire into the SVC. On the left side, the dome of the metaport was removed and it was cannulated with glide wire. The tubing was taken out and then advanced, and then an advantage guide wire was exchanged so that bilateral subclavian vein angioplasty could be performed at the same time. And then here's the pictures of the deployments of the stents in the left subclavian vein and right. Once the right stent had been placed, it showed an area of high-grade stenosis, which we were able to perform angioplasty on. And then here are some resulting pictures after the ballooning and stenting, and it showed after performing the angioplasty on the right side, we got improved flow in the area of the greatest stenosis. We used a balloon again to improve after the stent was in, flow on the left side as well. So the completed venogram after this was done gave a satisfactory improvement of patent flow. So, and then, like I said, we removed and replaced her metaport and got that cleaned up for her. And then afterward, the patient tolerated the procedure well with no complications. We hope to see less congestion and more patency seen with the angioplasty and stenting. We're going to follow up with her in clinic, and then the patient's metaport can now be accessed as needed. But then 8 days after that procedure, the patient was readmitted again for swelling in the neck and pain again. Patient mentioned that she heard a pop in the morning and swelling followed. So we brought her, she got CT done, and it showed right subclavian vein stenosis again with the indwelling stent, and then the right internal jugular vein showed stenosis as well. So we went back in to do another procedure. This is what we did on the second time around. So we used a right femoral vein approach for the right subclavian stent and cannulation. We did angioplasty with ballooning, deployment of basically a stronger stent over the last stent we did in the right subclavian. But we had to use a right axillary approach for that one because the balloon was not, the stent wasn't long enough to reach from the femoral. And then we did some right internal jugular vein cannulation and angioplasty with that. And then we ended up doing some kissing balloons performed at the junction of the IJ and subclavian vein stent that I will show pictures of. So here's the angioplasty of the right subclavian with that new stronger stent deployment. And this is the internal jugular vein with that high-grade stenosis where it basically goes into the SVC along with the subclavian vein. And then this is a picture of those kissing balloons where we ballooned at the same time the subclavian vein and the internal jugular vein. And we got some good results after doing the ballooning and stenting, and we're satisfied with the new patency of flow. So after that second procedure, there was no other complications. She tolerated the procedure well, and like I said, we'll continue to follow up with her to make sure that there's no reemerging stenosis. So we're going to follow up with her in clinic. But so for discussion on this case too, her presentation of SVC syndrome was she had a lot of things working against her. It was probably a combination of the stenosis of the bilateral subclavian veins, the clogged metaport catheter, the endobronchial mass on the right side, assumingly from the metastasis, putting external pressure on the SVC. And then when drainage of the head and upper extremities are impeded, the body will attempt to compensate with collateral flow, which we did see in this patient with her upper extremity, right upper extremity collateral. Intravascular devices are the most common cause of these central venous obstructions. A meta-analysis followed patency outcomes of SVC, subclavian, and brachiocephalic vein obstructions treated with angioplasty and stenting. Results showed 81.5% remaining patency up to 1 year after the stenting, but after the year, it started to decline. So that's why it's super important to closely follow up with these patients for possible reintervention and long-term patency. And those are my references.
Very good. Any questions, please? Any questions, please? It's an interesting case. So case presentation here. The patient was seen post-op day number 1 a few days ago, and she's doing quite well. And the edema of the right neck has markedly improved, and she was discharged without further complications. This was an interesting case because we were able to, second time around, go from the femoral approach to enter the stent. Pre-operative CAT scan was indicating that she had thrombosis of the stent. So that's the importance of doing an intraoperative venogram. So with the femoral approach going up, we're able to easily get the wire into the pre-existing right subclavian stent and did a venogram, which demonstrated stent was pain, but there was some still high-grade stenosis of the stent, which we're able to treat with a wall stent and to improve flow. Unfortunately, the stent, wall stent was not long enough to get to the subclavian stent completely, so we had to stick the axillary vein on the right side to gain access into the stent, then deploy the new stent that way. And furthermore, because of the edema of the right upper extremity, we elected to cannulate, because also the CT also said there was a thrombosis of the jugular vein on the right. So, well, to confirm that, we stuck the vein percutaneously with the micropuncture needle, and we did a venogram and saw that the vein was patent, but then there was a high-grade stenosis, and we're able to manipulate a wire through that high-grade stenosis into the SVC, then did a kiss and balloon technique, which helped out well. There's that possibility we could put a second stent in the IJ also, but I elected not to do that this time. This was a great case. That patient did well, and hopefully she'll continue to do well. Any questions from the audience before we wrap up?
Dr. Oye, I mean, did you guys put this patient on anticoagulant to prevent recurrent, to reduce chance of recurrence?
She's been on anticoagulation even before this surgery. She's been followed by hematology oncology, so she's been on long-term anticoagulation. I think she was an Eliquis prior, and she was given some Lovenox also during the hospital stay. But she was discharged after second intervention without any problem. She looks much happier, less edema of her face from the SBC syndrome. Also, something I must mention on initial surgery, she did have that Mediport on the left side. The Mediport was completely, the left subclavian was completely like Dr. Downs had mentioned. Again, one technique, if you take the Mediport out, that's it. You would not be able to restore flow ever get into it again. So for clinicians in the audience, if you have a Mediport like that in the subclavian vein, and you're concerned that if you take it out, that's the end of the show, you may want to cannulate the Mediport with a guide wire, take the Mediport out, then put a sheath in, of course, then balloon the subclavian vein, which we did in this case. Then we did a venogram and found the most critical area of the subclavian vein that was stenotic, nearly occluded. Then we were able to balloon, didn't respond well with the balloon, and we stented it. Then we put the Mediport back. that way she has that access because of the chemo needs. So that was the very cool case that we did the first time around. Cooler case the second time around because we had to go through the idea to make the kiss and balloon technique work for the patient. All right, so that being said, if there are no more questions from the audience, it's been a pleasure having you on today for our global ground rounds for this quarter. We hope our next global ground rounds would be scheduled for June the 7th, Saturday mornings, 9 a.m. to 11 a.m. And again, we also would like this opportunity to thank institutions to push this program forward. Okay. So we pretty much would like to say thank you very much again for the opportunity to join us today, and we enjoy having you on today, and we look forward to seeing you on June the 7th with more interesting cases. And if you do have any exciting cases in your clinical practices that you think would be helpful for clinicians and all healthcare providers to learn from, please do not hesitate to contact us so we can at least feature your cases and other global round sessions. So thank you very much, and I hope you have a beautiful weekend. Thank you so much.
Thank you. Thank you. Thank you. Bye.
Mhm.